Well, hello everybody. My name's Kay Wilson and I'm the South East Regional Chief Midwife, and it's absolutely marvellous to be here and marvellous to see this actually taking shape. And before I go any further, I must first of all say a huge thanks to Lucy and to Kate, because they're the ones who've pulled this together with a team, obviously, but so much work has gone into it. I've been a nurse and a midwife for a lot of years, and to see this now on the agenda is absolutely fantastic. For so long, we went through a stage when I first started that, there wasn't as much waste. Then as we got used to having all of these different things around and we came through the single use of everything, compounded by, I think, COVID to some extent, waste has just seemed to grow and grow and grow. And really, we all have to take a step now to make sure that it's not just in our own lives. We've all got recycling bins. I hope you're better at doing it than I am. We need a GCE where I am to try and get it right, but I do my level best. But we also need to take that into workplace and actually look at sustainability, not just of services, but how can we keep everything going well, look after this planet, and look after the environment. And in the, just to be totally honest, and in the spirit of full disclosure, my carbon footprint this week is appalling, because I've just been to Tenerife for a weekend and I wanted to get that out because I can see Charlotte Easton sitting on my screen directly in front of me, who's in my team, and she's my conscience for some things. So I know she might just make me feel a bit twitched. So my apologies for my carbon footprint. But getting on to more serious notes, yesterday I obviously missed the webinar, but we were talking there about the ageing population and really the impact that's starting to have. It's going to double in the next 25 years. We've got to seriously look at lowering these carbon models of care and see if we can look after people outside of hospital where possible. And that's so much better for their well-being as well. And that means that we've got to start as well looking at what can we do to reduce the issues that we're having. So these unnecessary emissions, and I was flabbergasted when you look and see the impact that the National Health Service has, the footprint that we have, that's scary. So it's fantastic to look at some of the work that's going on. And there's a net zero clinical transformation work stream that's looking to take a holistic view of end-to-end care delivery using a clinical patient-centered approach to meeting our net zero targets while we are delivering high quality evidence-based care. And that means we have to transform things. So it's really exciting. We've got a fantastic programme today. We've got 3 super speakers coming along. Jo King is going to be coming along talking about respiratory illness and sustainability. And she's going to talk to us about improving respiratory care with the positive co-benefit of reducing emissions. Somebody who has asthma, I'm really interested to hear about this. Then we've got Smither coming along to talk about infection control, reducing the overuse of sterile and non-sterile gloves. This is a huge thing. As a midwife, we've ended up with a situation where so many people just got into the habit of using non-sterile gloves when actually they didn't need to do that. Dreadful for the environment, dreadful as well for the cost, and we're constantly being reminded of that. So really looking forward to hearing about that. And then finally, we've got Rebecca, who's going to come and talk to us, and I think Kate as well, who are going to talk to us about the carbon footprint of the virtual wards in Hampshire. This is fantastic, really good. How can we get that care away from our hospitals? What can we do about it? So really looking forward to hearing more. As you'll see, I embraced the theme. I am wearing green, as I promised Lucy and Kate that I would. I've even stuck on my Queen badge, so I try and look a bit royal for this, because I had to follow one from Andrea Lewis yesterday. So I'm doing my level best. But without further ado, I'm going to hand over now to Jo. Really looking forward to hearing this. Thank you very much.
Thank you. I'm sorry, I was a couple of minutes late. I had problems getting in. I don't know what's going on with Teams in the next couple. Well, the last 2 days has just been mayhem trying to get in. But there you go. Anyway, I'm going to talk to you a little bit about inhalers and the green agenda. I'm Joanne King. I'm a respiratory consultant nurse for Frimley Health, and I'm the clinical lead for the respiratory services across the ICS and also the ICB lead. Sorry, for respiratory. So if you just want to, next slide. I'm assuming I haven't got any control, so I can't. That's fine. Okay, so I just wanted to reset where we were with things, so and what the issues were really. So as you've already said, the NHS is a massive contributor to greenhouse gases. One of the largest organisations, obviously, in the world and the biggest in Europe, and employs over 1.3 million staff. So it's not surprising, really, is it, that we are one of the biggest culprits. But a lot of the issues around the carbon footprint and what we contribute to it is coming from the NHS, and so there is an ambition that we look at reducing that, and there are some pretty steep targets, as you can see there. Some of them have gone by already, and some of them are approaching very soon. I have to say, when I was looking at this, I'm not actually sure where we are on this in terms of an overall as an organisation, but I do know that in terms of our ambitions around reducing the carbon footprint of inhaled therapy is doing very well in our local area anyway. I think overall across England, actually, the carbon footprint of inhalers is reducing quite a lot. So the NHS long-term plan often wants us to shift to these low carbon inhalers that deliver a massive reduction of 4%. And I know that seems like small, but if everybody does that kind of 4%, then it's quite big, and that we can reach this target of low carbon impact, or reducing the carbon impact of inhalers by 50% by 2030, which is not a million miles away now. So that's what we're on to doing. So next slide. So I just thought I'd give some people who may not be aware of how much carbon footprint you would expect to see for an inhaler. And I do have to be a bit cautionary with these figures and slides, because like everything, it depends on how it's counted, it depends on how it's made, it depends on where it's made, it depends on where it's transported, it depends on lots of different things, including how much negation that pharmacy companies are doing to try and offset their carbon footprint on where we are with this. But generally, we are talking about metered dose inhalers, and I promised myself that I'd try and get hold of one and put it in front of you, but I failed. I'm sorry. But I'm sure everybody has seen a metered dose inhaler, and the most common one to be seen around is the blue one, which was always seen as the most common. Most kids were running around with one in their pocket, and that they are given out quite freely. Now, some years ago, as part of the completely gone out of my head now, begins with an M, but an act that happened, we had to change from the carbon propellants to the lower carbon propellants. And in that point in time, patients really complained about their inhalers because they said that they weren't working as much. And what was happening was, when they were taking their inhalers, usually directly into their mouth, which we don't recommend anymore anyway, was that what they would do is they'd take the inhaler straight into their mouth, and they would get what was called a kick from the inhaler, which would stimulate the back of the throat and make them feel better. And when we switched to the low carbon inhalers at that time, or the low carbon propellants, patients complained that their inhalers weren't working anymore because they're not getting it. So some of them, a lot of inhaled therapy is very psychologically driven for patients. It's something we need to be really aware of when we're trying to make sure that they're on the right medicine, because if we don't persuade them or go through that shared decision making of which inhaler is it that you think you can use, what can you get along with, and so on and so forth, then we're not going to get buy-in. But one of those metered dose inhalers, or PMDIs as they're known, basically has roughly a carbon footprint of 180-mile drive, which is fairly substantial when you look at it. And yet the dry powder inhalers, the DPIs, are 18 times lower in terms of their carbon footprint. Now, both have plastic involved. That plastic is not recyclable, but I think there is some controversy going around. I haven't been able to find the article, which I spoke to Kate about last week, that said that actually the plastic is quite high. But I think we have to bear in mind that both have plastic, both have metal. So what we should be looking at is the propellant that is in the MDI. So when you look at 150-mile petrol journey, it's about 35 kilograms of carbon dioxide equivalent. Fluticid and Symbicort metered dose inhalers are really high, because different metered dose inhalers, as you can see, are also a higher carbon footprint. So we don't use those in Frimley, or shouldn't be using those in Frimley. And then Ventolin EVA inhalers, which are quite common, are a little bit less, and we've moved down to lower, and we use now Salamol. or Aramea, which is equivalent to a 33-mile petrol journey, which is much better, obviously, than that 115-mile at the top of the chart, but still not enough. If we switch people to a dry powder inhaler at this point, then we'd be looking at less than 1 kilogram of carbon dioxide equivalent. So you can see that actually switching to a dry powder inhaler is really, really important to offset our carbon footprint. Next slide. So there's been a couple of position statements around this. So the BTS, the British Thoracic Society, had a positional statement in 2020. NICE have had some statements released, and then there is also alongside that you've got the association. So you've got the Association of Respiratory Nurses, and you've also got Primary Care Respiratory Society, all of who have a statement on sustainability and what we should be doing about that. And the general rule of thumb is that we should be trying to get patients to take a dry powdered inhaler whenever it's feasibly possible, and that means that they need to be able to take it, and we should switch from MDIs. That's the bottom line of the messaging. But what needs to go back into that whole messaging is about how important it is that your patient can actually take the dry powder. Because if the patient can't take the dry powdered inhaler, then you get poorly controlled disease or illness. And poorly controlled illness is driving greenhouse gas emissions as much, if not a lot more than anything else. So for me, the underlying message of everything that we do in respiratory when we're looking at changing inhaled therapy, whether it be for the green agenda or for clinical reasons, is that we should be making sure that our patients are as clinically well as they can be, and that we are doing the best thing for those patients. Because if we do that, then we will automatically start to reduce our carbon footprint as an NHS. So a well-controlled patient won't have multiple journeys to hospital, they won't call ambulances, they won't have excessive ED attendances, they won't admit to hospital, and they won't take up those beds. And therefore, the whole overall picture is much, much safer than it is if we had switched somebody to an inhaler that is less well controlling. And there was a lovely little study in the thorax that was published recently, actually, that said that the average amount of carbon emissions generated from a person whose asthma was not well controlled is 3 times higher than that of those that have got stable disease, which is huge. 90% of excess emissions are driven by the inappropriate use of short-acting beta agonists, which are those blue inhalers. And actually, asthma care has changed ginormously over the last few years, and now we are advocating that no asthma patient should be given a blue inhaler, and they should be treated only with what we call dual therapy. So they need to have inhaled corticosteroid in their inhaled therapy at all times. And that helps with the control of their asthma, which is the driving force of that. But of course, the offsetting part of that is that we don't have those MDIs around as much as we did. Next slide. So this is the paper that I've just talked to you about. So it was in the Limbic. If anybody wanted to look it up, you're more than welcome to. Really quick study which talked about this, and they did calculate that overall the national carbon footprint for asthma care in the UK is about 750,000 tonnes, which is massive. But poorly controlled disease equates to nearly half of that. So all of our greenhouse gas emissions, over half of what we're producing is driven by poorly controlled disease. Next slide. So I wanted to share this with you. This is really hot off the press. It was only released last week, very timely, I thought, and has been endorsed by all the major societies. And it is a visual aid for patients with asthma. Now, we are concentrating on asthma a bit more in terms of the green agenda, because asthma patients generally are able to use a range of inhalers, whereas COPD patients maybe not quite so much, and have less ability sometimes to activate that dry powder, and therefore need to have a PMDI and spacer, which is obviously a much higher carbon footprint but they need it for control. So this is a really nice visual aid that's come out. There's been a lot of bad press about this in terms of asthma patients saying that they felt guilty using their inhalers. There were reports in the papers about patients that admitted to hospital because they stopped using their inhalers because they were guilted and shamed into not using them because they were contributing to the carbon footprint and greenhouse gases and so on and so forth. And there was one article in the paper, I think it was the Daily Mail, that had a screaming headline of asthma care equivalent to eating 3 tons of meat or something along those lines. So it was all very, very negatively in the press and advertised. So this is a really nice visual aid for people just to go through asthma reviews, just to talk to them, do they understand their asthma? Do they understand what good control is? Do they understand what adherence is? Do they understand what they need to use to benefit? And then talk through those things such as triggers of air quality and so on and so forth, and then talk to them about using their inhalers. So this is the cornerstone of respiratory care. It's not just a matter of prescribing or using an inhaler. You have to actually show me how to use it, and you have to demonstrate you're able to use it. Otherwise, you don't get prescribed. Next slide. So they go through this whole inhaler review and they talk about whether or not they can actually activate a dry powder inhaler and can they do it. And if they can, then they would be asked, would they be prepared to take one? Now, even if they're able to, they may say, no, I'm not doing that. I hate it. It's in my mouth. I don't like the taste. I don't like this, don't like that, don't like the other. And again, we have to respect that. So we have to counsel through that. We have to talk about their choices and why they might make those choices. Good care being the cornerstone of that. But at the end of the day, if a patient doesn't want to use them because they prefer a different device, which might well be a propellant device, then we have to respect their wishes because their good quality care and their good control is more important. But we would consider obviously reducing the MDI footprint as much as possible into dry powder. Next slide. This is the biggest message we're trying to get out at the moment, that all unwanted or unused or used inhalers should be returned to the pharmacy. They shouldn't be put in the bin. They're ending up in landfill. They should be medical disposed of. There's usually quite a lot of propellant that's left in the inhaler if they've got a propellant inhaler, and that can be medically disposed of. There's often a bit of powder left over in the dry powders. Obviously the plastic can't be recycled as we'd like it to be at the moment, but it's still better and much more safer for the environment to have this going back to a pharmacist for medical disposal. Next slide. There's some resources that come with the greener practice bits and pieces. So there's a whole heap of resources. I haven't done them all here, obviously. I'm quite happy to share some links with Kate to put out there to all these projects, how you can have these aids to visualize and to talk through with patients who are becoming much more environmentally aware and will often ask you, well, hang on a minute, what's all that plastic doing to the environment? What's my inhalers doing? So you need to be aware when you're prescribing and be prepared to answer those questions. Next slide. But I did just want to point out one thing, that, PMDIs, they are a big problem. They are part of the problem. But, out of everything, those F gases, which are the issue, are a very small percent of what is causing the problem. And actually, we shouldn't forget about all the other things like refrigeration, air conditioning, poor procurement, transport, all those things. Medical aerosols are a really small percentage of this. So I'm not by any means saying they're not an important percentage. They are, and they are one that we can work on, which is brilliant. But we do need to remember that it's not just, it's quite small in the big picture. Next slide. And then these were just pointing out some of the things that people don't think about. And I think that for me, it was the residential, commercial, and industrial air conditioning and refrigeration. 50% is driven by that. So we really need to look at that. And obviously then you've got your cars and transport. So Kate and I were talking about this, the virtual ward care, more community care. What cars are we all driving? How are we managing that? How are we doing that? And I think the last slide. So these are my 3 take-home messages. So the top one has to be that good clinical care is what's going to reduce the NHS footprint across the board, not just in respiratory, but definitely in respiratory in terms of inhalers. Consider greener options, but make sure they're appropriate, and encourage everyone to take unused medicine, not just inhalers, but definitely inhalers, back to pharmacy. And that's it.
Absolutely marvellous. Really, really interesting. I've learned heaps. And I think that's just, it really set it out really, really well as well, Joe. The fact that it pulls it back to we're wanting to provide good care, and actually that's what's key, but at the same time we can be making a difference, and they're significant. I had no idea about that. 100 doses is like 180 miles. I mean, that, and when you think about some of us who weren't doing it right in the first place, it was not doing what it should be. Brilliant. Really, really enjoyed
people
it.
that like to test their inhaler before they take it that can't see. Let's just pump one out there anyway, just to make sure it's still working. So
I didn't do that, I can promise. And it was spot on time. And what we're going to do is we'll go through our speakers, and then we've got time at the end for questions.
Yeah, I'm really sorry. I did say to Kate, I've got a clash, but I will keep an eye on the chat. And if I can pop back in, I will. Okay.
That's absolutely marvellous. Thanks so much.
No problem. Okay then. Bye-bye.
And now we're going on for our second speaker, and this is Smitha, who's going to talk to us about promoting safety and sustainability through reduction in overuse of non-sterile gloves. I'm dying to hear this bit as well. Go for it. I do hope I've said your name right.
Absolutely, you spot on. Thank you so much. Good afternoon, everyone. My name is Smitha Anil, like Kay introduced, and I am from the Infection Prevention and Control team from Berkshire Healthcare. I am joined with Diana Thackeray, who is my head of service, and we'll be sharing the presentation. Thank you. As you're probably aware, there are national initiatives for glove reduction, and many organizations have implemented this, and I'm sure many of your organizations, you have seen this happening. We are here to give an overview of our implementation project and experience titled Promoting Safety and Sustainability Through Reduction in Overuse of Non-Sterile Gloves. Next slide, please. Thank you. So for those who don't know Berkshire Healthcare, we are a community and mental health trust providing a wide range of services to people of all ages living in Berkshire. Our staff operates from over 60 sites across Berkshire. We have 5 main hospital sites with a combination of inpatient, physical, and mental health wards. Our staff work in diverse settings, which include inpatient, outpatient, communities such as patients' home, care homes, and commission services. Other services include urgent response teams providing virtual wards and home assessment for admission avoidance, a minor injury unit, and out-of-hours GP services across 3 localities. Specialist community services include community dental, podiatry, speech and language therapy, pediatric specialist teams, and our mental health teams working in the community. Most importantly, we have both clinical and non-clinical staff working in all these settings. So therefore, any IPC promotion or initiatives need to be considerate of all settings and services provided given the diversity of our organization. Next slide, please. Thank you. We are all aware of the implications of overuse of gloves. Not only can it lead to missed hand hygiene opportunities, transmission of infection, and risk of dermatitis, an organization's carbon footprint is directly impacted by waste generation, and increased carbon emission from manufacturing and transport lead to increased financial implications. In our experience, in addition to the clinical safety implications, a large enabler for staff engagement and discussion has been generated directly from the implications on the impact of our environment. So that has been a motivating factor. Next slide, please. So the project update. So following review of national work streams, we developed the project vision to improve appropriate glove usage by increasing staff awareness. And this vision was aligned with our organization's goals for harm-free care by adhering to appropriate use of gloves, good patient experience by raising staff awareness and development of accessible and diverse resources, including patient service user feedback. Supporting our people by providing targeted training, supported visits, and empowering staff to undertake risk assessment when to wear pair of gloves. An efficient, appropriate use of resources to support the sustainability agenda and improve financial saving. Next slide, please. As in any improvement project, engagement with stakeholders was key to success. For staff, so we had conversation and awareness sessions were undertaken with staff prior to the project to benchmark staff understanding. The PP supply team, we used our central PP supply team to understand the annual use of gloves across the organization. The PP request team has also streamlined the process of issuing gloves to reduce unnecessary wastage. The Royal College of Nursing resources were utilized to develop bite-sized training in various formats, including presentations and videos. Resources were launched at our Infection Prevention and Control Link Practitioners Forum for increasing local awareness. We also linked in with our Trust Sustainability Group and Waste Management Group for further collaboration. And later in the project, but most importantly, our patient forums were utilized, which can assist with promoting patient and public awareness and expectations. Next slide, please. Glove usage data was obtained over a 12-month period. This was obtained from our central PPE supply team, which provided glove supplies to all services within the trust and was used as our baseline data. Over a 12-month period, we found 3 million gloves were used, just about 3 million gloves. So we looked into that figure and we did some calculation, especially looking at the sustainability implication of that. So based on a national tool, we calculated our glove usage to equate to the carbon footprint associated with this amount. And we identified a travel distance of nearly more than 200,000 miles. One single glove can lead to 26 grams of carbon emission, and it can take up to 5 years to disintegrate. So you can imagine that plastic pollution leading to toxic effects and can affect the ecosystem. We also looked into the financial implication, and the total amount of gloves totaled to a financial implication of more than £146,000. But this is not including the cost for waste management. It was purely the procurement and transportation. So these figures made a huge impact on staff. Next slide, please. We developed diverse resources in varying formats, accessible for all staff and based on staff feedback from our initial launch. Some of the national tools were adjusted and scenario-based resources were produced. A dedicated section on our Trust intranet page was developed where all resources could be easily accessed. A list of common indications for use of gloves was developed to support staff. Monitoring of staff compliance was commenced on the inpatient units, enabling us to address learning in real time. Ongoing review of glove usage at regular intervals was undertaken following the implementation of the project. Our estates and facilities and non-clinical teams were also included in the resource dissemination. Next slide, please. So a PDSA cycle was reviewed regularly throughout the first year to ascertain if further resources, support, or training opportunities required. Feedback from staff and successes in areas were identified and disseminated to streamline implementation. The project outline and purpose were included in our IPC mandatory training and bespoke bite-sized training produced to support staff with implementation in their own area. Next slide, please. As you can see, after 1 year and using the same process as for collecting the baseline data, we were able to share a substantial reduction in glove use, cost, and reduction in impact on our carbon footprint. This was shared with our IPC link practitioners and staff in a variety of ways and by providing regular updates and sharing of good news stories, and we were able to maintain momentum with the initiative. I will now hand over to my colleague Diana to take you through the rest of the session. Thank you.
Thank you, Smitha. So the outcomes included continuation of promotion of patient and staff safety. We were able to streamline the procurement processes and issue of gloves to departments. There's been raised and increased awareness of the initiative, both within the organisation and the wider ICS systems. We've had wide engagement from other clinical staff, clinical and non-clinical, from stakeholders and discussions in the key group, as Smith has previously mentioned, such as sustainability and the waste groups, and within the wider organisation. So not only did the data reflect a reduction in glove usage, we were able to provide positive reinforcement by undertaking support visits and monitoring glove usage and providing real-time feedback and scenario-based training. There was, as we've already said, significant improvement in the financial savings and related reduction in our carbon footprint. And the infection control team and our staff were really proud to be part of the efforts in sustainability of our environment. And this was celebrated at our annual infection control link practitioner study event. Next slide, please. So what did we learn? As with any change or initiative, positive reinforcement was key in supporting behaviour change. A lack of understanding of all of the potential impacts can lead to an overuse of gloves, and this applies to both staff and patients. I think it's already been mentioned, but not to underestimate the impact of PPE use during the pandemic and what it's taken for subsequent confidence and building confidence with risk assessing for the use of PPE. I think during the pandemic, it was very prescriptive and there's been some work around that in terms of increasing staff confidence for risk assessment. Factoring in patient and public expectations, and what we have identified is patient involvement can really help greatly with messages around this. We identified the need for a suite of resources. One size does not fit all. As previously mentioned, we've targeted training and that supports understanding. We can all make a difference with the ongoing promotion activity. Importance of empowering our local champions. Our link practitioners have been really enthusiastic about this and have led some really significant changes in their own clinical areas. And I think the main thing is to actually harvest the enthusiasm for sustainability, because that's been a really key factor for this and its implications within healthcare. And that sustainability can support safe care and initiatives with real-time results that can benefit all. Next slide, please. So what's next? Continued support and focus on our inpatient units. We're looking at monitoring staff compliance and providing continuation of the supportive learning. We've disseminated the resources to our community nursing teams with a plan for a rolling programme of implementation to all community services. And this includes the raising awareness as part of the community service visits we've got planned for next year. Continuation of PDSA cycle as part of the quality improvement project. Review of glove usage, including calculating the cost associated with clinical waste and travel, which has been previously mentioned and not factored into that figure that we'd had after our first year of the project. And looking at expanding our patient collaboration. So next slide, please. In the absence of specific infection prevention and control questions in patient feedback, so for example, I want great care looks a lot around in cleaning in the environment. Patient forums were asked what IP precautions meant and what would be useful for them. We put together some specific questions around that. And actually what came back was their highest concern was sustainability. So it wasn't around hand hygiene, it wasn't about infection rates, it was around sustainability and what organisations were doing about that. And it generated an awful lot of discussion around how post-COVID they felt that there was much less in the public eye about infection prevention and control. They raised questions about the impact of costs and the contradiction between pushing for less waste and the increase in single use. So, for example, during COVID, PPE, curtain changes, paper towel, cleaning products, etc. They also identified branding and language and how to get attention easily, use of social media and other tools that are available to us, and the fact that they wanted conversation rather than a written survey. So looking at real engagement rather than just asking for feedback, and raising the profile of prevention through strategies before admission, how the public and patient groups can help with that in terms of myths, myth busting and giving messages. And then they also talked about the reduction of travel and carbon footprint. So what actions have we undertaken? So we have looked at social media. We're increasing our promotion for public messages via a variety of platforms such as TikTok. There's a plan for increasing patient and public involvement in IPC promotions campaign for 2024 to 25. And utilising our Berkshire Healthcare Health Bus, which goes around the whole of Berkshire with other services, with patient involvement, collaboration. And we've linked in heavily with our patient experience team, including feeding back to HealthWatch. We initially set our questions to HealthWatch, and we're hoping to attend the next meeting to give feedback to what we have done. Utilising our patient safety partners and lived experience practitioners. And focus on outcomes for other sustainability programmes. So we're obviously continuing with the glove reduction, but we're also looking at another of other sustainability projects throughout the organisation. So reusable tourniquet trial, reusable sharps bins, review of bin placement, etc. In an aim to reduce our clinical waste. Next slide, please.
I'm going to have to call you last minute.
I'm on the last slide. I'm on the last slide. So the three take-home messages really that we wanted to get across from this project was that key patient and staff safety messages can be promoted and implemented with sustainability and carbon reduction objectives that are clearly linked, and in our experience, a high priority for both our patients and staff. Staff inclusion in identifying adaptation of resources useful to them promotes positive and sustained engagement, and our patient collaboration engagement within infection prevention and control highlighted sustainability in healthcare as their main area of concern, with enthusiasm to be involved. Thank you.
Absolutely fantastic, marvellous, as I always say, marvellous. It really is. I mean, that has pulled in so much that everybody can get on board with. It's ticking so many boxes, improving outcomes. It's also helping with the financial position, but that green effect, that's huge, absolutely huge. I'm not going to take up loads of time now because I'm going to move us on and then we can come back to questions later. But thank you both very, very much. Absolutely incredible piece of work. We're now moving on to Rebecca and Kate, who are going to talk to us about virtual wards. Over to you.
Thanks, everyone. Yeah, you, Becky, do you want to kick off?
Yeah, so hi. So I'm Becky Housley. I'm actually the consultant nurse overseeing the Virtual Health Hub at Hampshire Hospitals, which I'll explain a little bit more about in a minute.
And for anyone who doesn't know me, I'm Kate. I'm the programme manager in the South East region in the Greener NHS team, and I've been working with Hampshire Hospitals on this project.
So I just thought I would open up the presentation, just talk a little bit about what we offer and what services we are supporting to give you a bit of context. So like I said, I'm the consultant nurse overseeing the Virtual Health Hub at Hampshire Hospitals, and that consists of 3 services. So we have a telemedicine service to support care homes, and so care homes can ring us with all acute deteriorations, and we will manage remote consultations for those patients in their own homes, trying to keep them safe and prevent them coming into hospital. We also have a clinical communication centre, which supports as a single point of access into our hospitals to support with direct admissions and medical advice. And we also take ambulance crews at scene, so we can try and streamline patient referrals and make sure they're seen in the right place at the right time and by the right clinician. And most importantly, we have our virtual wards, which is what we're here to talk about today. Now, it's just worth noting that all three of our services actually all work in harmony together, and without all three services they wouldn't almost work. So we have 8 specialist virtual wards at the moment, and Kate's obviously going to give you a bit of an overview on the carbon impact that we've seen and seen the savings that we've seen through supporting patients on our virtual wards. So obviously, as you know, virtual wards are here to support patients remain well at home, to support patients not coming into hospital, and also prevent support with early supported discharges. So our team is mainly nurse-led. I'm a consultant nurse and I'm the sort of lead for the service, but the rest of my team, I do have some physios in my team, and I also have a pharmacist. But what's really important to note is that because we are a virtually led service, we all have the opportunity to work from home. So that prevents nurses needing to go into work every day, and they don't need to drive, etc. But we have 2 hospital sites, and we always encourage them to use the bus when they're working.
Oh, you've gone muted, Becky.
Sorry, can you hear me again?
Yeah.
So on our virtual wards, obviously we do remotely monitor patients, and we do send out some remote monitoring such as oxygen saturation monitoring and blood pressure monitoring. We always try and encourage the patients to return the oxygen probes at the end of the day, because obviously we don't want them just throwing them in the bin, or we encourage them to keep them. So if they have another respiratory infection in the future, that we can use the same piece of equipment. We don't want them throwing this in the bin every time, because A, it's really costly, but B, it's really it's not great for the environment. So they're really the key things I wanted to get across. But we are a non-medically led service, and I think from my perspective, we've never had problems with recruitment, because the opportunities to be able to work from home and also work in the hospital has been super valuable for our staff. And actually the impact of not having to get in our car every day, and patients also being able to be supported at home and not being having to be managed in hospital, we're seeing huge carbon savings, which Kate's going to now talk through as part of the rest of my presentation. So please ask me any questions at the end. It's a whistle stop of what we do, but Kate will explain more about what we've seen.
Thanks, Becky. So yeah, we've talked a lot about COVID being a bit of a pinnacle moment in healthcare and the changes that have come from that with the PPE, but we've also got to recognise the changes in healthcare as a result, and treating people in a more virtual way. So we know that inpatient bed days have quite high carbon factors associated, and we think that virtual wards has a low carbon factor, but we haven't really looked into this. So this is the first sort of jigsaw piece of a big puzzle that we're trying to sort of navigate. So we've had a really fantastic group project between myself and Hampshire Hospitals. There was a bunch of us. There was Becky, who was consultant, a pharmacist, someone who worked in data analyst, project management, and 3 sustainability specialists, including myself. So it was a big group effort that went into this project. And we started by setting ourselves the 3 objectives that you can see on the screen, and we really wanted to look and understand the carbon footprint for Hampshire Hospitals virtual ward, identify any carbon hotspots, and really capture the benefits of a virtual ward versus an inpatient stay. It was really important to set these goals out initially. It's really easy to stray away from the scope and really identify and pin that down. And we looked at the journey of the patient from admission to discharge. It wasn't just the virtual wards element. Luckily, we had a toolkit that helped us from the National Greener NHS team, and they provided some pre-populated carbon factors for things like an inpatient bed day and ambulance travel, which really helped the process. And we created a visual map of the patient pathway for acute respiratory infection and frailty patients. We picked out the carbon factors for each carbon activity point and basically added everything together. The methodology that we used was pretty robust. So we started off with a sample size of 30 patients that one of the clinicians sort of manually and painstakingly went through all the patient notes and picked out those carbon activity points. And that really helped us to inform the larger data drop from the BI analyst. So altogether, there was 1,260 patients that we reviewed over a 13-month period in a retrospective cohort analysis. The detailed records review really helped to inform the larger data drop. We were able to pick out exactly what activity points we were looking at and any anomalies. We were able to really fine tune for the larger data drop. So it was really helpful. And so we looked at the findings in two sort of processes. And the first one was to look at the average kilograms of CO2e per patient per day. So as you can sort of see on this table, we know that the really high dependency wards have the really high carbon factors associated, as you would expect. And then you can see that the inpatient bed day has about 37 kilograms of CO2e attached to it. What you start to see going down there is what happens to a patient's carbon emissions when a virtual ward is introduced to their pathway. So for patients who had a virtual ward element to their care, their average carbon emissions per day went down from 37 down to 18.1 for the large scale analysis, which is pretty significant. And then when you look and fine tune just to the virtual wards element only, we're seeing a massive reduction to just 8 kilograms of carbon dioxide per patient per day. Most of that was associated with the home emissions. So we had 7.4 kilograms of CO2e for home energy usage, which you could kind of argue if they're living in a care home or if they have anyone else living at that home, then that's double counting. But, you know, there's that argument to be had. That was in the national toolkit. That was the advice we got given. So if anything, this is a high overestimation is what I'm trying to say. So we're really seeing that true reflection of carbon emissions for virtual ward being the actual low carbon model of care, which is fantastic. The second analysis that we did was looking at prevented carbon emissions. So some previous work done with Health Innovation Network, or AHSN as it was then, calculated a methodology to look at the bed days saved. So for that patient cohort, it was calculated that an estimated bed days saved was about 6,064. And we used that to calculate what the avoided carbon emissions were. So for that patient cohort, we got a massive 283,000 kilograms of CO2e that was avoided. That's pretty hard to understand. And Chris, I'm really glad you've been talking about the journeys to space and back within the chat there, because we did something similar. So we converted it to miles travelled. That came out at 726,000 miles travelled, which is just shy of travelling to the moon and back, or driving to the moon and back, as a prevented carbon emission. So yeah, we were really, really pleased with that finding. I think it's a bit of a mic drop moment for us when we found that. We still found some carbon hotspots, and this is why it was really good to look at it through the patient journey and not just the virtual wards element, which we know is a really low carbon factor. So we found that frailty, particularly the frailty patients, there was a high percentage of them getting to the within their patient journey using an ambulance, which we know is a really high intensity way to travel. We looked at it a little bit further and found quite a high percentage of those frailty cohorts weren't spending any time in an inpatient bed day afterwards. So it begs the question of whether they could have used an alternative mode of transport and not those really high, big vehicles, diesel guzzling ambulances that we have. We know that a large percentage of the patient cohort attended A&E, and that was their admission into either inpatients or straight to the virtual ward. And again, we know that A&E is a really resource-intensive environment. So again, it's about looking at that referral route and seeing if there's any way that we can start increasing the number of direct referrals where it's clinically safe to do so. And then we also found quite an interesting element, which was the diagnostics transportation. So there's 2 hospital sites, and one hospital site has a much larger capacity for diagnostic testing. So there's 6 journeys being done per day, which equates to about 240 miles a day happening, which equates to about 20,000 kilograms of CO2 over that time. So if we can get that one vehicle swapped to an electric vehicle, then we're seeing a huge reduction in those carbon emissions straight away. So it's all things that we're working together on. We were really lucky enough to present these findings at the Healthcare Without Harm conference at the end of last year, and we've got lots more planned for this project. We're going to try and do a formal write-up of it. We've really I think we've looked at it in quite a unique way. There's lots of other projects that are happening that are just looking at the virtual wards element. So we've kind of done it in a unique way, but really pleased with how we're looking at it in a more holistic way. And then, of course, all researchers want more research to be done. We recognise that there's loads of different variations in virtual wards, and some have much higher face-to-face interaction, which is naturally going to increase the carbon emissions. So, as I said at the beginning, this is the first sort of piece of the puzzle of a much bigger sort of jigsaw that we want to complete. And I think that's everything that I have to say. So any questions are more than welcome.
Fantastic. Again, just incredible to see. And it really does help when you put things like the number of miles and what that equates to, because it does set it out. Loads and loads of thumbs going up here. Nick has just said, you mentioned a formal write-up is there to help, which is fab.
Thank you.
Any questions at the moment? And then I think we're going to do a bit of a roundup. Keep me right though, Lucy and Kate. I don't want to go off track. Yeah. I can frequently. Any questions, anyone?
Stunned into silence.
Yeah, I think so. I think it'll be one of these later on. It'll be loads and loads of questions coming up. Or maybe keep the link, or that we can post them tomorrow anyway, because we're going all week with these. I think for me, just to kind of sum it up, it's really interesting. I think when I started as a nurse and you asked a question, if I was told to do something, we were doing something, and I asked why, generally at that stage, and this was in the 80s, the answer would be because I've told you to. End of story. And you learnt, and I was quite obedient in those days. I'm no longer obedient. I think one of the fabulous things now is that not only ability to question, but actually that responsibility to question and to challenge. Why are we doing this? Is there a better way? But as well, pulling in this, it's so important. These issues don't sit on their own. Every single one that we've talked about, we've mentioned about appropriate care. Whether it was from the asthma care, the respiratory care, that we need to do what's right for that patient. For the gloves, we need to make sure that we are actually giving care that isn't going to increase the risk of harm, which if you use them inappropriately, that's potentially what you're going to do. And the same with our virtual wards. If we don't need to have people in hospital, why are we doing that? Why can't we do it better? We've seen that there was benefits from the pandemic. It's made us think of doing things differently, but it's also highlighted we started to use equipment and things and PPE that now we've got to scale back on. But I think the key for me is to be green. If we're going to be green, like I am today, this doesn't mean that we have to cut down on working for our outcomes. This all goes hand in hand with trying to improve outcomes for the people that we're looking after. Getting a grip on healthcare as opposed to ill healthcare, asthma, keeping them fit and well, the virtual wards, keeping them where they need to be. And at the same time, in a very economically challenged area and time, this has the benefit of reducing costs, which means that we can then plough back that money, those resources, into hopefully improving outcomes through prevention. I think it's incredible that, 3 fantastic presentations, absolutely inspired. And my final point for me is this is the first time for the International Day of the Midwife, which comes up in May, that being green is actually mentioned in it. Thank you, Charlotte, who sent me that. I give my credit to Charlotte Easton here. But that, again, it's there. It's at the forefront of everyone's mind, and that's where we need to keep it. So a huge thank you from me. I'm going to hand back now to Kate and Lucy for anything else.
Thank you, Kay, for sharing brilliantly, and just to echo your thoughts, actually, just in terms of that roundup, 3 incredible presentations, and I think it's really just empowering. There is so much that every single person can be doing, and nurses and midwives and our shared colleagues are just doing brilliant work in this space. Kate shared the Care Without Carbon website. I put it in the chat box, so it's got some brilliant ideas on there for you to use as a resource, but also to upload your own ideas and your own initiatives. And they're probably the main bits for me. Kate, did you want to come in?
No, I think that's everything. Thank you for supporting us on this week, and I hope to see you tomorrow, really.
Looking forward to it.
Yeah, tomorrow's theme's children and young people. We've got 3 more speakers tomorrow, and then stay with us for the whole week. So thank you everybody for joining and being part of this.
Absolutely marvellous. Brilliant, everyone. Thank you.
Thank you.